Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So we've spoken a lot here about time, and all three of us have expressed impatience. And I'll certainly share that I hear from patients a lack of patience. And so let's flip the question on its head, right? All three of us have expressed that we want the answers yesterday. And we've talked about the technologies that might help us to have them as quickly as possible, but recognizing that we live in a very imperfect world. If it were perfect, we wouldn't have lung cancer. Let's talk about the question we actually face together with our patients, which is that we don't have the results back. And we're in a situation where it's either jump to chemotherapy or wait. Dr. Dagogo-Jack, what does that look like in practice? How are you dealing with that? And how are your patients together with you as a team dealing with that?
Yeah, and I think that the way that we've been dealing with it as a patient and a provider is really the anxiety and the symptom burden to really dictate how we proceed. There are some people, so all metastatic lung cancer is not the same, right? Some people have minimal symptoms, and in that case, we're able to wait and get all the information and proceed in the most informed fashion. But for others, I'm meeting them in the hospital, where their cancer is very symptomatic. And I think what we have learned over the last few years is that the absolute wrong thing to do if you are in a population where there is a high likelihood of having an actionable alteration is to actually add immunotherapy. And that for everyone's instruction basically is because there's increased toxicity then when you start the targeted therapy. And so for me, I do start chemotherapy in some patients if I think that the molecular testing is going to take entirely too long. And if I find an actionable alteration, then you can backtrack a little bit and start the more effective therapy. I think the important thing is keeping someone there as long as possible. And we've seen that disease can advance pretty quickly in some cases. And I would rather not kind of miss that therapeutic opportunity.
Yeah, I share that practice. I think that immunotherapy, beyond that it can make TKI less toxic, many of our changes, particularly EGFR and ALK and RET, are also really strong negative predictors of IO working, meaning that patients with EGFR, ALK, and RET are much, much, much less likely to get a response to immunotherapy. I wish it weren't true, but it is. And while we're not supposed to talk about the toxicities of immunotherapy, I think our culture is that it's wonderful. The truth is that, like all medicines, it does sometimes hurt patients, and I don't want to risk harm if there's not going to be benefit. So, if I'm pushed to start early, I start with chemo, usually PEM-carbo or PEM-carbo-bev. I will not give immunotherapy until I know that there's a chance of it working and that I'm not going to need TKI. I would also say that in my opinion, there's not enough waiting going on. I think anxiety on the part of doctor and patient and loved ones is very understandable. But I think and time matters a lot, right? Lung cancer doesn't sit around and wait, but it's time to doing the right thing that matters, and that helps people, not time to doing something. And I think that I see a lot of therapy that I might call premature that really didn't need to be given. I think that when I look at the landscape, at least of the most common changes that we see, like EGFR, ALK, RET, ROS1, the overwhelming majority of the clinical scenarios I see really could wait. They're not badly symptomatic patients. And while we do care deeply about the suffering of cancer, chemo causes plenty of suffering also. I don't have to convince this audience of the suffering that chemo causes. I think there's not nearly enough waiting going on.
Yeah.
I don't know. I'm a recovering New Yorker saying that, so maybe I'm the least valid person to express the merits of waiting, but it's the right thing that matters.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.